This is Lance Lichter for AA Today. Cardiopulmonary bypass use and bleeding, a study in neonates. Adult patients who require transfusion following cardiopulmonary bypass are at increased risk of adverse outcomes, including death. Such studies have been done in children as well with similar results, but none have previously been limited to neonates. Neonates may be more likely to bleed after cardiopulmonary bypass. The fixed bypass priming volumes are proportionally larger for neonates, thus causing greater dilution of clotting factors. Their coagulation system is relatively immature, and their procedures can be longer and are undertaken at lower temperatures. The authors retrospectively examined the relationship of bleeding to outcome in 167 neonates who underwent complex congenital heart surgery with cardiopulmonary bypass between January 1, 2010 and December 31, 2011. The results of their analysis are presented in the article Excessive Postoperative Bleeding and Outcomes in Neonates Undergoing Cardiopulmonary Bypass, which was published in this month's issue of Anesthesia and Analgesia. Chest tube output and transfusion requirements were correlated. Patients who were more likely to bleed, all values comparing bleeding quartile less than or equal to 75% versus greater than 75%, weighed less, 3.1 versus 3.0 kilograms, had longer cardiopulmonary bypass times, 132 versus 154 minutes, had longer aortic cross-clamp times, 66 versus 77 minutes, had lower lowest temperature, 25 degrees centigrade versus 19 degrees centigrade, had greater regional perfusion time, 0 versus 38 minutes, used deep hypothermic circulatory arrest, 0 versus 1 minute, were more likely premature, 8% versus 7%, and had higher risk adjustment for congenital heart surgery scores, indicating a more complex procedure. Postoperative outcomes were worse for neonates who bled more. Time from protomine to time out of the operating room was greater, 89 versus 99 minutes. They were ventilated longer postoperatively, 73 versus 143 minutes, spent more time in the intensive care unit, 7 days versus 10 days, and 72-hour creatinine was greater, 0.7 versus 0.8 milligrams per deciliter. Outcome data was also worse for patients who bled more. The need for dialysis was greater, 1% versus 6%, as was the need for ECMO, 3% versus 11%, though in-hospital mortality was not greater. And though mortality was greater for infants who bled more than the 75th percentile, conclusive statements regarding mortality are difficult due to the study's small sample size and the fact the study came from a single institution. Previous studies of children, including infants, had similar findings. Nonetheless, this was a well-written and researched paper, and the authors have made an important contribution since the study was limited to infants at their institution. For links and more, go to aatoday.org. That's AA2day.org. This is Lance Lichter.